Before I welcome our guests, I'd like to invite those who have not already done so. Please subscribe to our YouTube channel, Magnimind Academy. We upload recorded sessions of these talks so you can watch them later. And you can also comment any questions or just thoughts on our YouTube channel below. I'd like to welcome now Michael Zelenetz and his talk, Healthy Choices, Where to Apply Data Science in a Hospital. At Magnimind, we really try to find speakers who can give workshops or talks that give a different kind of information, or maybe just more support information that go along with our data science education programs at Magnimind. These programs range from focusing on the fundamental skills of data science all the way to helping into a career change into the industry. Our goal at Magnimind is impacting as many careers as we can, and this is just one way that we do so. I see there's an echo. I'm going to try and mute myself. Did that fix anything? All right. Michael joins us as the new Director of Data Management and Analytics at White Plains Hospital in New York. Before this, he did similar work for New York Presbyterian Hospital for over 10 years. And before that, Zelenetz got his BA in sociology from Yeshiva University before going on to Harvard's master's program for a degree in computer software engineering. We've had a lot of different speakers about healthcare and data science, and I'm extremely excited to hear Michael's insights concerning the specific area of data science. Please now give your full attention to Michael Zelenetz.
All right. Hi. I know. I tried to turn my video on, but I don't know if you can see me, so you can just imagine somebody very good looking. All right, so thank you for coming. So yeah, thank you for that introduction. I, like he said, have been a New York Presbyterian until this week, where I am just starting a new role as the Director of Data Management and Analytics at White Plains. So a very different experience. The goal of this talk is really we're just going to talk a little bit about data science in healthcare and areas where data science is helpful and areas where it's not helpful. Maybe more importantly, we'll talk about some of the unique challenges that healthcare faces in terms of data science and healthcare data in general. And then we'll talk about some, along the way, we'll sprinkle in some war stories about some of our successes and failures, which I think is sometimes more interesting than successes. There are many, many different facets to data science and to sort of healthcare. I sort of break them down this way. I'm sure other people would break them other ways, but I sort of think of healthcare companies and data science in healthcare as having sort of four primary functions. You'll have your consumer-facing apps like, I don't know, Noom, ZocDoc, wellness apps. You have your sort of business-to-business services like consulting and services and Kensai and those sorts of like data platforms and business products. Then a big part of healthcare is you have payers. So your like Anthems, your United Healthcares, right? Insurers, and then the providers. And I'm sure I'm leaving out pharmaceutical companies and other areas, but I think of these as sort of the main areas in healthcare proper. And I'm only talking about providers. The other stuff is interesting. I know very little about it because I have not worked in any of those areas. So tonight, when I say healthcare, I'm talking about healthcare providers. So healthcare providers meaning clinics, hospitals. That's what when we say healthcare providers, we mean those who actually do the administration, who actually do the healthcare. So I liken healthcare to being on a large ship, especially in a hospital. There's so many areas in a hospital. It's almost like a small city. You have logistics, you have finance, you have linens, food service, obviously the actual clinical functions, and also like a ship, it's very hard to turn. So Healthcare is sort of very rich in its history, and it's a very large and very interesting area to work in, right? But we're not known for being nimble or agile. So there's a great article by Atul Gawande from almost 8 years ago, where he compares healthcare or thinks about healthcare as like the Cheesecake Factory. He says some things that the Cheesecake Factory does really well is they have very little waste. They can forecast very accurately, how many cheesecakes or pasta dishes they're going to sell on a given night. They know, how Super Bowl Sunday is going to impact their sales, and they're very lean, but they also offer a very wide variety of types of dishes and very high quality, I guess, for their sort of competitors. This is a great article if this is something you're interested in the New Yorker from a few years ago. I reread it every couple of years because it really speaks to me and the kind of work that we do, which is trying to make healthcare safer, affordable, higher quality, leaner, right? And the sort of the area that we work in. So why should you work in healthcare? I mean, and why is healthcare an interesting area for data science? So, we've all seen variations of these charts, but healthcare costs trillions of dollars a year, and the costs have only gone up. Even when you adjust per capita, the expenditures are still continuing to increase, and a huge portion of that is in spending on hospitals and providers, so physicians, clinics, and hospital care. And of those, a huge amount of it is sort of in very acute care. The costs of insurance and health expenditures have only continued to increase, and we're starting to see a lot of interest and pressure from both the provider side, from the payers, from the federal government, in how do we control this explosion in costs, and how do we really rein it in and offer cost-effective care, but also very high quality care. So some of the so that's sort of why you should come to healthcare from a job security perspective, right? But in terms of we're data scientists, we want to play with interesting data, we want to do interesting things, we want to have big impacts. So we're always interested in what's the type of data that we're going to work with. So some of the data that I work with, obviously you have your electronic health records data. This is when you go to your doctor and they write notes and they put in orders and they write prescriptions, right? All of that is within the electronic medical record, and both structured and unstructured data, and we'll talk about that in a bit. You've got your laboratory results, like your blood tests. Orders could be anything from your dietary orders to procedures, to medications. You have your actual medication administrations, like how much medicine the nurse actually gave. Vital signs, both. Now we're measuring vital signs automatically off of. We're streaming them directly from the bedside. Like in New York Presbyterian, we were collecting 2 gigabytes of data per bed per day, just from the regular vital signs, and EKG waveforms, and central venous waveforms, and all of that very rich, interesting data. You have scheduling and your admits, discharges, and transfers, and that's sort of your classic healthcare provider hospital data sources. However, now as data science becomes more prevalent and processing power and storage becomes cheaper, we're starting to see a lot more interest in sort of the bottom half of the slide. So we're seeing a lot of movement in patient-reported outcomes. So, for example, at New York Presbyterian, they're sending patients home certain types of patients home with like an iPad, and maybe a blood pressure cuff and a scale, so that they could take their own vital signs, upload those vital signs through the iPad, and then answer questions like, how are you feeling today? Are you feeling short of breath? Do you feel generally well, generally unwell? And really, I think what's very interesting is that healthcare has expanded so much outside of the four walls of the hospital. And, as healthcare providers and as hospitals, we're becoming more like quarterbacks of the healthcare system. And we're starting to see, this is sort of a general trend, that we're starting to see a lot more sort of data from outside, and we're following patients, beyond just their single hospitalization, but we're trying to sort of build and maintain relationships with patients, both inpatient and outpatient, and over the course of their lives. Some of the other things we're looking at are things like imaging, like CT scans and ultrasounds, echocardiograms. I'll try to touch on some of those use cases later. I mentioned electronic medical records. A big part of electronic medical records is the clinical notes. And, there was historically not a huge amount of work done on the clinical notes, just, because they're tough to deal with. But there's so much very rich information that's locked in clinical notes, that's, in unstructured fields. Even more than just sort of what's happening with the patient, we're seeing, you can, if you are sort of attuned to how physicians write their notes or nurses write their notes, you can almost start to see, pick up on sort of their sentiment. And so one of the things that we had sort of thought about getting into was like using sentiment analysis for clinical notes to understand, is the physician or a nurse concerned about this patient? And there was some work from our colleagues at the Columbia Nursing School that showed that just using clinical notes, they were able to detect patient deterioration, or to predict patient deterioration, because they, the way that people sort of word their notes can be indicative of the fact that they're concerned about a patient. So a lot of interesting work there. There's other work there aside from just clinical, in terms of, revenue cycle and our coding and billing, in terms of looking at through the notes to do a better job of capturing diagnoses and diagnosis codes. And diagnosis codes are essentially how the hospital bills. So, by doing a better job of capturing the diagnosis codes from the clinical notes, you'll make more money, but you'll also sort of do a better job of representing how sick a patient actually is. It's also very important for research because diagnosis codes are used very often for cohorting patients, or for as inputs to other machine learning models or to other features. So it's really important for us to understand to capture as best as possible all of the diagnosis codes associated with a patient's visit. So one thing that I think is really exciting, this biometric data, is we now have the ability to implant like a device. We have a device called Link, which we're implanting under the patient's skin, and is able to capture things like the patient's fluid status, their heart rate, their respiratory rate, their motion, and that even a simple EKG. And that data can be broadcasted through the patient's phone, and can either be, depending on the model, will either upload when the patient gets close to a docking station, or through the phone will go, in real time into their medical record. And I think there's a lot of really interesting work that we're going to see coming down the pipeline with that sort of data. We're using it to keep an eye on our really sick, sort of our borderline heart failure patients. And I think we're going to see a lot of really interesting work there, and we'll be able to do a lot of interesting and really important work for the patient's well-being. We're also looking at RFID data. So as you move through the hospital, in your ID band, is at least in some places, we're embedding an RFID tag so that we know the position of our staff members, our patients, equipment, which allows us to do some cool things like, when you walk up to somebody and you're lost, they can pull up on their phone, see who you are and where you're supposed to be, and direct you. So make like a very friendly concierge type service. But also to really understand how patients move through the building, and to design processes that make that as little friction as possible. And then there's genomic data also coming down the pipeline. The types of things that we focus on in healthcare, I would break into the buckets of operational efficiency, and I think you can kind of see this already from sort of the data we've collected and the types of things that we're interested in, but sort of three arms. So you have your operational efficiency, your quality and clinical quality, and then what I call data products. This is how I sort of tend to think of it. So operational efficiency, I tend to think of like, how well are we staffed? Do we have enough staffing for our anticipated patient load? I'll talk a little bit about a project we did with staffing and forecasting. Cost reduction. So just looking at sort of all of the ways that we can be more efficient and be leaner. And then revenue generation, like I noted before, how can we identify things like secondary diagnoses that we had missed earlier. So just as an example, we did a project, a joint project with the Columbia Business School, where essentially what happened was a doctor came to us and said, we're really interested in surges in the emergency department. And I said, what? What do you want me to do with that? Like, what is a surge? What are you trying to do here, right? And she said, I don't know. So she said, I don't know, we'd really like to know when we're in a surge so that we can send additional resources to the ED. So they want to send more nurses, they want to open up additional CT scanners. And so I thought about it and I said, well, it sounds like what you're actually trying to do is you want to predict whether a surge is coming, right? Because once you're in a surge, it's sort of already too late. You're already playing catch up, right? You want to know, is there going to be a surge in the next, 12 hours? And she said, what is this, sorcery? And I said, it's not sorcery, it's math. Anyway, so what was kind of interesting was that, you think even though arrivals in the ED and the emergency department are kind of random because emergencies happen, at random times. It turns out that that's not the case, and that there are actually fairly predictable patterns in the emergency department, which means that it's, maybe amenable to forecast. So not to sort of go too deep into the details, but here's an example of using a deep learning model as a GRU to forecast the census. The orange here is the predicted census, and the blue here is the actual census over the course of a number of hours. So this is hourly census in the emergency department, and you see it does a fairly good job. So that's exciting. As I promised, we were talking about some of our failures. So obviously, when we're trying to predict surges, it's tough to predict surge, given that we penalize predicting extreme values. So these are pretty. This sample here happens to be sort of a pretty normal week in the emergency department. So it does a fairly good job of capturing that. Although you see it, not perfect. But it does not do a great job of capturing very extreme values. So that's sort of a limitation. But what was interesting is sort of the way that we built this was, step one is we said to them, well, when do you guys think you're busy? Like, what is the intuition? And we heard a bunch of different answers, like we're busy on Mondays, the day after a holiday is always busy, flu season gets much busier in the emergency department. Some people say, I don't know, there may be some weather, maybe the snow makes us busier, maybe there are more car accidents. I don't really know, but we feel like something with the weather. So, we did a lot of work and looked at a bunch of different models and different variables. And here's sort of an interesting tidbit we found. So here's one of the many models that we ran, and I just looked to see sort of the best and worst residuals and looked to see if they could find some patterns in the days that we did poorly on. And we found that if you look through this list of days or shifts, we see like 12/24, so that was like Christmas Eve. 11/24 is, I think, a Thanksgiving or maybe Black Friday. So we see, all right, so there were some holidays here that we needed to include. So, okay, fine, we'll include holiday indicators. And then I looked at some of these other days, which weren't holidays, and I said, well, why did these perform so badly? And we looked at just Googled the dates to see what was happening in New York City at the time. And on a lot of the days, there was a blizzard, which was interesting. So these are days where the actual number of arrivals was way less than the expected number of arrivals. So we found that there was at least in terms of blizzards, they tended to reduce the number of cases that were in the emergency department. And we found that one of the problems that we had with weather, and this is something that we found consistently also in the literature, was that using weather as a continuous variable didn't do very much to improve the efficiency of our model. Like looking at sort of temperature as a continuous variable didn't really help. Precipitation didn't really help. And it was even bucketing the variables really didn't do much to help the performance of our model. So I thought a little bit more about this. And, and the other thing is, you want to make sure that when you're forecasting something or when you're training something, you want to use training data that's as similar to the data that you get in production. So it's kind of cheating to use precipitation totals, because it's not necessarily going to be available to you. You may have forecasted, if you had forecasted precipitation totals, that may be more useful. So I didn't love that idea to begin with. And what I ended up finding, there was one day here where there was we expected a very big blizzard in New York City, and they put out a weather a blizzard watch or blizzard warning, and there were all these news articles about this massive blizzard that was coming our way, and it turned out the blizzard never panned out. It never even snowed. We didn't even get a dusting, but we still saw that day was impacted by the anticipated blizzard. So I thought, well, maybe it's not so much the snow itself, but the sort of anticipation of the snow. So we added a feature to our model, looking at the expected, if there was a weather warning for that day, issued by the National Weather Service, and that actually helped our model perform better on those extreme weather days, which is very interesting. Some of the other features that we look for, we're trying, when we're predicting emergency department arrivals, we're trying to find effects as far upstream as possible. So there was a paper a few years ago which inspired me to look at flu trends. So the Google team put out a paper, I believe, with I don't want to guess wrong, another university that was found that they were able to predict flu season, or the severity of flu season, based off of Google searches. So I use the Google Search Trends API, and it's not perfect because it's a relative number, and we can sort of talk about that at a later date if that's interesting to you. But we see here, so towards the end, there's COVID. In the middle, 2017 was a really bad flu year here in New York. And we saw that in our ED data as well. So this is very interesting, and you can see sort of the cyclical nature of searches for flu and flu symptoms. And then we look for other things that may be seasonal, and certainly, here in New York, when it's dark and gloomy in the winter, people tend to get a little depressed. So we do see some cyclicality to depression trends. So we added that into the model. Yeah. So, there's an interesting example. However, like I said, we're going to talk about some of the ways that it failed. So, after we did this and we had this discussion and we talked about whether this forecast would work and whether this was the right approach, and we came back and we thought, well, what is the forecast horizon that makes sense, right? Like, if you had a surge for 3 hours, that was, if we could predict 3 hours ahead of time, that there would be a surge. Is that enough time, or do you need 12 hours? Do you need 24 hours, right? How far in advance does that have to go? And then once you have that, well, what are you going to do with it? And those kind of tied together, because we said, well, if you're going to call in additional staff, then knowing 3 hours ahead of time is not enough time to call in additional staff. And also, the duration of the surge matters, because if the surge is going to be in 3 hours and it's only going to last for 2 hours or 3 hours, then you can't ask people to come in for 3 hours. It doesn't really make sense. And like, how are you going to serve these findings, right? How do you give these back to the leaders in a way that's useful to them? Like, I found that once people have to log into something to look at it, they almost never look at it. So, putting into, everyone wants a Tableau dashboard until they have a Tableau dashboard, and then, nobody ever looks at it again. So, that sort of became a struggle. Like, how do we actually make this operational? And then we had I don't know, the epilogue is that we had a plan to do that and to study prospectively, and we were working with Columbia Business School on sort of a staffing model and how to implement this, and then COVID happened and destroyed the whole thing. So I don't know. So healthcare data is hard, and doing data science with healthcare data and doing machine learning with healthcare data is extremely hard. Some of those reasons are because just the data availability. So given that healthcare data is so is personal, it's private, there are laws around it for good reason, right? It's hard to share data and to get good data to train on. And for example, there's a especially data that's identifiable. So like finding clinical notes is nearly impossible. I think the Mimic3 database is probably the only one I know of that has publicly, semi-publicly available data set for notes. But getting good training data outside of a payer or a provider, and even like for training for that sort of like NLP type tasks and training, and blanking on English words. That data is very hard to find outside of a large hospital, and so a place like New York Presbyterian or large hospital systems, it's a great place to work if that's the kind of thing you're interested in, because we just have so much data. And New York Presbyterian had EKGs going back to the mid 80s, which is just unbelievable. And then once you have the data, getting good ground truth and getting good labels is extremely hard. So for example, we did a project where we were trying to identify patients with heart failure. And heart failure, I don't know if there are clinical folks here, but heart failure is sort of a range of a number of there are different types of heart failure. It's sort of a range, a broad label that we put onto many conditions. So even coming up with what does it mean to have heart failure and who has heart failure and how do you identify patients with heart failure is is a difficult problem. So getting really good quality labels can be very hard or very time consuming or very expensive, right? If you have to ask humans or physicians to, manually label data, training data can be extremely expensive and extremely time consuming. We also have issues of, data quality. So like, for example, there's missing data. We don't necessarily know, depending on the outcome you're trying to study, we may not even have the data for the outcome. Like if you're trying to study mortality and patient deaths, if the patient didn't die in the hospital, it may be very hard for us to know that whether the patient lived or died. You can look at the Social Security Death Index, and there's some other external data sources you can buy, but they're not great, and it can be hard to match them back into our electronic medical record. So it can be very hard to do that sort of work. And so that's what we call censoring, where there's data that's either your outcomes are missing or your inputs are missing. Maybe, if we're trying to find patients with diabetes, a patient could come to us with diabetes, but if we've never seen them before, we don't know necessarily that they have diabetes, right? And especially if it's not well captured in their diagnosis codes or in a clinical note, like that may slip through the cracks. So we don't have a full history of the patient, before their encounter with us or after their encounter with us. So some of the things that we work on in terms of operational efficiency, we've talked about sort of length of stay, patient flow, cost reduction. Quality tends to be interested in sort of deterioration and risk models, risk of like sepsis or infection. I'm going a little fast here just to try to get to some more interesting things again. And then, like I said, there are products, and I tend to think of this as, data-enabled products and services. So, things like taking a block of text and predicting if an ICD code is present there. ICD code being a diagnosis code, right? A patient recommender. So, if, for example, we want to find patients with heart failure who we should enroll in some sort of, follow-up program or a community paramedicine program, for example. So we, looked to see which patients were most at risk for, either deterioration. In the case of the community paramedicine, we were trying to the metric we were trying to move was heart failure readmission. So we looked to see which patients were at highest risk for readmission, and then said, okay, well, start with the most at risk and work your way down the list, right? Or the ED forecast, as we spoke about. So some of my pearls I can bestow onto you are, don't make a list unless it's someone's job to look at that list. So for example, a lot of work in healthcare goes into making these patient lists. For example, I want a list of every patient in the hospital who has heart failure. I want a list of every patient who is at risk for deterioration, et cetera. The hospital sort of works off these patient lists. But you have to make sure that when you're making a list, someone's actually going to be reviewing that list. So, in the example of the heart failure case, we had the heart failure service hired PAs whose job was to review that list and look at the patients that were predicted and to determine, yes, this patient had heart failure, and would they be a good candidate for this program? But short of that, almost no, unless it's somebody's explicit job, they almost never look at the list. And then it's really important in healthcare to make sure that your outcome is well aligned to a strategic goal, which is often money, or at least at some point gets back to money. You want to make sure that, let's say, if you're trying to predict readmissions, there's a penalty that hospitals pay when their readmission rate is too high, and they get sort of bonuses for having very good readmission rates, right? So that's why that's a very common strategic goal, and that's why you see a lot of industry and data science and effort into around reducing readmissions and reducing length of stay. But if your outcome goal is kind of a cool research project, and I have many of those that never end up going anywhere because they don't really closely align to something that people care about. And these things are also expensive, so it's important to make sure that there's an ROI. And then think very carefully about what is it that what decision is your user trying to make, and when are they trying to make it. So you want your model, or the output of your work, to be as close to the user who's making a decision at the time that they're trying to make that decision. So, for example, if you're trying to nudge a physician who's to prescribe a cheap, a generic version of a drug as opposed to a brand name, which is going to be cheaper and just as effective. So you want to put that nudge like when they're ordering the medication, for example, and not at the beginning of the visit before they think anything about prescribing medications. So thinking about what the decision you're trying to make and how to put it as close to their sort of natural workflow as possible is really important. And this is hard because the electronic medical records like Epic, Cerner, Meditech, Allscripts don't tend to play terribly well with external input and integration with people like us who are trying to hack at it and take their job away from them. That's how they see it. So it can be challenging. And very often the default is, well, let's just forget about the medical record and we'll have some external portal where they'll log in and they'll be able to see their patients, and they'll see the output of our model, and they'll see our risk score in this external thing. And I find that almost never works because clinicians and doctors are very, very, very busy people who have very limited time and bandwidth and sort of mental bandwidth and really dislike logging into many, many systems. So when you ask people to go out of their sort of primary work area and their electronic medical record, it's a very dangerous idea. So here's a sort of a cool project that we worked on, and a proof of concept. Again, was not very closely tied to a clinical outcome, but it's something I'm very passionate about and I think is very interesting. So hopefully you will also find it interesting, and we'll at some point in the future do something and run with it and let me know. And then we'll talk about it and it'll be exciting. So there's a story. There's a doctor, his name is Ignaz Semmelweis, and he lived in Vienna. He was an obstetrician. And Vienna General had this problem where there were two wards. So Ward A had this very high, like 10 to 15% maternal mortality rate, whereas Ward B had a very low maternal mortality rate. And they would admit patients to wards like even days to Ward A and odd days to Ward B or something. And it was very well known apparently at the time. And there were stories of like women coming, when they were due to deliver, and it was coming up on their due date, and it was an odd day, so they wanted to get into Ward B, and fearing that the next day they would go into labor and they'd end up getting admitted to Ward A, and they'd be knocking down the doors of the hospital trying to get themselves admitted on Ward, on an odd day into Ward B. And Dr. Semmelweis looked at this and he said, well, what is the difference between Ward A and Ward B? I mean, Ward A, they both use, Ward A and B, they both use the same techniques and they have the same equipment, and the patient population is the same, as randomized. The big difference was that Ward A was staffed by physician trainees, whereas Ward B was staffed by midwife trainees. And what was happening, he realized, was that the physician trainees were training in the cadaver lab in the morning, and then were coming back from the cadaver lab and were seeing patients, and then their patients were getting sick and septic from diseases that they were bringing back from the cadaver lab. So his solution was he had people wash their hands, and that pretty much immediately solved the discrepancy between Ward A and Ward B. So you can think of this top path, this gray path, as a bad path, right? There's this, you have a graph, let's say, of nodes and relationships, and this relationship from Ward A to cadaver lab is representative of a bad path. So what we did was we took all of the data from the electronic medical record and the lab system from one of our hospitals from a year, and we threw it into our Neo4j, into a graph database. And we looked to see, can we find some of these bad paths within our data? And we targeted C. diff is a common hospital-acquired infection, which is really nasty and nobody should ever get. So we, and what we found was that there are certain patients where, there's this long tail here, right, of patients who providers who had a very high rate of patients contracting C. diff. And when you look at who these providers are, they're not like infectious disease specialists. So not necessarily that there's anything wrong with these providers, but this is maybe a path that you should take a look at. Like, these are maybe a dangerous node. Other sort of applications of graph databases is looking at delays in social work nodes. So we take the social work nodes and parse them and lemmatize and put those tokens into a graph database, and then we join on nodes that are connected to discharge delays, and we find those nodes that are sort of in that are common sort of common terms that are between many of the delays. And we found that a lot of the delays were driven by things that were known to the social workers when we spoke to them, but it was an interesting finding. Things like holidays and issues with payers that were causing delays in getting patients out of the hospital. So delays in discharging patients out of the hospital. So I'll take questions. Here's my contact information if you have any questions. So there are two questions I see here. So the first one being, what statistical methods were used for predicting surges? How was faulty data dealt with? Or other domains of data that were consulted for ground truth? Okay, excellent question. So in terms of surges, so first the question here was, how do you define a surge, which may be your question to begin with. Like, how do you even know that you're in a surge, right? Like, and that was something we struggled with, was first, how do you even label a surge? And we started thinking about this as a sort of a binary question of, surge or not surge. And then that's why we sort of went to just a forecast where we thought about it more as like a, continuous variable. Faulty data in terms of surges, is that in terms of surges or in terms of other areas? If you could put another question in there, perhaps. But that's an excellent question and something that we, in general. Okay, so so the question is, how do you deal with faulty data? An excellent question. Probably a talk in and of itself. As you might imagine, given that there's so many manual processes here, we see a lot of faulty data, or workflow issues that can cause incomplete or contradictory data. I don't really have a great answer for how we do this in general, because I think it's very specific to the use case. And it's a much better question than I have an answer for in like 2 minutes. Yeah, I don't even know how to address that. What are other domains of data that are consulted for ground truth? So that's a fantastic question. When you're trying to ground truth, for example, does the patient have heart failure? So diagnosis codes are great, but not perfect. I think in general, our approach has been go as far upstream as possible. So I'll give you an example. I'll give you an example of one of the projects that we were working on before I left, and one of my favorite projects that I've ever done, and I am sad that I will miss out on seeing the fruit, it bear fruit. But one of the things that we were working on was using machine learning and deep learning, looking at image data, like for example chest X-rays or echocardiograms, and the and EKG tracings, the raw waveforms, to try to predict certain subtypes of cardiac abnormalities. So, for example, aortic stenosis, which is like a sort of narrowing of whatever, doesn't matter. But the point is, instead of relying on looking at clinical notes for evidence of aortic stenosis, or looking at diagnosis codes, we went right to the source. We went to say, how do physicians make the diagnosis of aortic stenosis, and how can we try to find that right for as close to the point where they make that diagnosis, or as close to the same the way that they make that diagnosis. So I think that that's a really interesting approach, and I think that that's going to be very important, sort of in the future of healthcare, and as access to data and processing has become has made those approaches more feasible. Another question was, what is the most important thing that a hospital that hospitals care about that we can gather from data science? I see it, operational efficiency, et cetera. Yeah, another great question. So there are a couple of recurring themes that I see in hospitals. Almost everybody has a readmission risk model. Almost everybody has a sepsis model. Very frequently we see deterioration risk, so like clinical deterioration. So is a patient going to wind up in the ICU in the next 24 hours? Length of stay, right? How long is a patient in the hospital? Those are the kinds of things that are like the bread and butter of hospital data science. And like I said, so those operational efficiency things I think are really important, and being able to do as well is super valuable. Like I said, capturing secondary diagnoses is also super valuable. We see a lot of companies and departments who are trying to do a better job of, let's say, finding diagnoses within notes, or within structured data like labs. From a data management perspective, how is the investment at your hospital right now in terms of hiring data engineers to make the data as clean as possible and making it easy to deliver pipelines of data like the data lake? All right. Well, to be totally frank, so the hospital I'm in right now is in the last 2 days, is much sort of near Presbyterian, for those who may not know. where I came from, is a very, very large hospital, one of the largest in the country by bed count. Has 11 hospitals within the network, and has a very sort of robust data infrastructure. The hospital I'm in now is a very small, is a part of a larger network, but is a very small hospital. I'm coming into, they have almost no data infrastructure. And most of what they have been working with is using Excel out of canned reports. So we are building that sort of from the ground up. So in terms of hiring data engineers, we will be looking at that in the near future. And building out those pipelines is what they brought me in for. So TBD. Other questions. Who sees the results of these studies? Are you doing presentations to management? So that's a great question. So often our requests are coming from management or from institutional sort of strategic goals. So for example, that network analysis thing, that was sort of a I don't know, kind of proof of concept that we had worked on in response to a strategic initiative to reduce our hospital-acquired infections. We wanted to see if that was a good avenue to go down. So we do, work very closely with hospital leadership, and we work very closely with sort of clinician partners, which is super critical and probably something I didn't highlight enough, but very critical to the success of anything is to work very closely with, frontline staff and frontline management. Since we need to make these decisions, and most of them have the result of, does this make the hospital more money or save money? Do you have to run an analysis on the operations side and familiarize yourself with it before you can even jump into any special projects? That is an excellent question. One thing, and I don't want to make it seem like all that we care about is making money or saving money. It just happens to be that, I would, maybe it's a little pessimistic. I tend to be a little more optimistic, and I really do. My experience has been that people in healthcare and in hospitals, and one of the reasons I've worked in healthcare and hospitals my whole life is because I really do feel that people who work in hospitals are really do care about patients and safety and giving the best and safest hospital experience. It happens to be that very often these quality and patient safety goals are tied to financial outcomes. So it's very easy to sort of make the case for, we want to invest, $100,000 in something that's going to save you $10 million a year, or it's going to make you $10 million a year. So tying it back to money, I think makes digesting that investment easier. And it's something that the business folks can understand. But I think it is very important to run an analysis from the operations side before jumping into something like that to understand what is the impact. So one example of a project that we worked on was trying to do a better job of capturing secondary diagnoses. And like I said, it's complex, but the long story short is that when you do a better job of capturing secondary diagnoses, it improves your quality scores, and it also improves your revenue. And you can tie, and we can test, and we can say, all right, without this score, we would get reimbursed, I don't know, $20,000, and adding this code, we would get reimbursed $25,000, right? So there's, we can say adding this code is worth $5,000. And then we can sort of make a projection if, how frequently do we think that we miss this code? And if we do a better job of capturing this code, what will that be worth to the organization? And, for example, we did in 1 year, we made about $8 million and just 40% of our units by just doing a better job of capturing, like, I think 11 diagnoses. How would you automate the process of finding faulty data? Oh, it's like the holy grail. So there are a couple of places where faulty data can come into the picture. So one is like, I meant to write 100 pounds and I wrote 100 kilograms. So, in those sorts of things, you can see, especially if there are trends, like we've looked at in those patient-reported data sets, for example, where they enter their weight, we would see sometimes they would get entered as pounds and sometimes they get entered as kilograms. And, we may say a patient say, 100 pounds, 102 pounds, 103 pounds, 100, and then 100 kilograms. So, 200 something pounds, 202 pounds. So, something close. Something changed. All right. Anyway, so you can use some things like anomaly detection to find some of those. Okay, it's back. And further down the pipeline, we've done some anomaly detection to look for, like, is there missingness in our notes? Did our feed go down, or is there a hole in the database that were missing notes? So is again a very good question, better than I can answer in 2 minutes, and it is very highly variable on sort of where in the process the faulty data is introduced. Do you only analyze historical data, or do you ever monitor or suggest conducting tests on whether a medication is effective for a certain disease or not? Excellent question. This is, so drug discovery is, I think, another area of healthcare, and something that my group does not focus on at all. We tend to stick to sort of the operational and quality side and products. But certainly like drug discovery, there's a lot of work to be done on drug discovery, finding bad interactions, genomics, lots of interesting stuff there, but not what we do. For Surge, did you use NEDOC score to determine load in the ED and predict that score? Yes, we used NEDOC and we used Edwin. We had a grant actually to look at other, to look at measuring busyness, and we did some work with trying to use a tool like there's something called the NASA TLX score, which is supposed to measure sort of how busy, the cognitive and physical load on somebody, and sort of meant for people in like industrial settings. And we tried to, and we correlated the NEDOC score and the NASA TLX and to try to get a sense of like, what does it mean? Yeah, like we said, maybe surge is not so much the number of patients, but how busy it feels. Because sometimes you feel very busy because you have a lot of very acute patient, very highly acute patients. But like you have fewer patients. And other days it's very, very busy, but everybody's like there for, sniffles and it doesn't feel that busy. So that's something we looked at. We didn't find a great correlation, and I don't know, we petered out. There was a suggestion, which you'll may find funny, to try putting a Fitbit, have everyone in the ED wear Fitbits, or somebody even suggested wearing EEG monitors to try to understand how people's cognitive load while they were working in the ED. And I said, I don't know, you want to do a shift in the ED wearing an EEG? I mean, that's like crazy, but whatever. How hard would it be to incorporate a good machine learning model that can predict clinical deterioration or pressure ulcer occurrence into Epic so doctors don't have to look elsewhere? All right. I will admit I am not an expert in Epic, although I've looked into this a little bit, and there are a couple of ways to do it. If this is something you're dealing with, feel free to like send me an email. just like quickly, one, Epic has their cognitive cloud, if you have the cognitive cloud license, which allows you to put your own models sort of into Epic, and it ties very nicely into their Epic ecosystem. I have never done that, and we didn't have cognitive cloud, but you can, it seems to like be more geared towards like linear models, and I believe that there's a way to package something up in Docker and to deploy it to the cognitive cloud. And there's a webinar in their user web from a couple of weeks ago about it. So I would look there. I think other things that we've looked at are building an app orchard app and then deploying your machine learning model as like either an external API or within that the app orchard would go out to, or within the app orchard app. And then you could write those results back into Chronicles. The third option is, I believe, like you could do it through an interface. Like you could have an HL7 message, which could write the output of your model into like a flow sheet. And then, you could build like a BPA or something, or an alert off of that flow sheet value. Anonymous attendee asks, any investigation via data done on hospital and clinical error? Great question. I think the most interesting work that I've seen on errors at our institution was a doctor whose name is escaping me. Okay, I'll look it up. He wrote a couple of really interesting papers. He developed a metric called the cancel and reorder metric, where it's sort of the electronic corollary of giving the wrong medicine to the wrong patient. So if you, let's say, have two tabs open with two different patients' charts, and you write, I don't know, Lexapro to patient A, and then you realize that you meant to write that to patient B, and you quickly cancel it and reorder the same medication in patient B's chart. So he looked at those errors, and he called that the cancel and reorder. And he actually did some really interesting work. He had med students watching for them in real time, and as they would see one of these come in, they would call the person who did a cancel and reorder and say, hey, did you order that on the wrong patient? And they say, yeah, I did. Sorry. And they go, no, we're just doing this for our study. So but yeah, that was super interesting work. His name I will look up in a moment. What's the most helpful COVID data to work with? Helpful for what? I'm not sure. If you could throw it in the chat again, I'm not sure. What do you mean by helpful? What are the features used for predicting secondary diagnosis? Curious if data like chief complaint was important. Yeah, great question. So, sorry, I should have qualified. So in billing land, there are only three diagnoses. You have your admitting diagnosis, your primary diagnosis, and secondary diagnosis. So your admitting diagnosis is your chief complaint. Your primary diagnosis is, at the end of the day, the sort of main reason for your being in the hospital. That's your primary diagnosis, like your main diagnosis for the visit, and then everything else is a secondary diagnosis. So for predicting secondary diagnosis, we would use things like, so we could use structured data like, the flow sheets or lab data, for example. So, to get diagnoses like hyponatremia, which is like low sodium, you would look at the sodium in the labs and you'd see, if it's low, and if it, it's less like a machine like that. That's sort of a more like a rules engine where you would say, all right, if the sodium is low and they didn't mention the sodium in the note, then we should nudge them. Hey, does this patient have hyponatremia? So that's, and then for other things, right, we did train some, I did some work on using some NLP techniques, like TF-IDF vectors to take to sort of vectorize a clinical note, and then to try to predict like what is the admitting diagnosis from based off of the first clinical note. Do you work with a large team, or do you run these tests by yourself? Also a good question. So for this week at my new job, I'm by myself. But my team at New York Presbyterian was, we had an infrastructure team of about 5-6 people, and then a few groups that were doing data science, totaling maybe fewer than 20. And a lot of these are some teamwork, some by myself. For helping healthcare professionals deal with COVID. Oh, this was, okay. The question here was what did we find helpful for helping healthcare professionals deal with COVID patients? Excellent question. So we did a lot of work very early on trying to just wrap our heads around what was happening and who was getting sick, and who was sort of on the mend, and who was not, and we did a lot of work with our partners at Columbia Medical School and Cornell Medical School, trying to understand which patients were most at risk, which drugs were at risk, and it seems very random early on. Like now it's sort of a little bit more clear, but who fares very badly with COVID, who does well, who's at risk to end up in the ICU, because we were seeing patients who would come in looking more or less okay, and then would just very, very rapidly deteriorate. And so there was a phenomenal paper preprint that NYU put out a couple months ago, looking at chest X-rays of COVID patients to predict intubation or ICU admission within 48 hours, which was a very interesting paper and a great idea. And I think, so we have some of that work that we did with, understanding what were the predictors of COVID were published in New England Journal of Medicine, JAMA, a bunch of the sort of leading journals. And so that was sort of our work with COVID, but very, very much, my team's work with COVID was much more in sort of building the infrastructure to answer those questions, or to understand, who are COVID patients, what does it mean to be a COVID patient, some very interesting existential questions about, so. All right. I've talked a lot. Are there any other questions? I think that's all.
Yeah, it looks like that was all the questions. Thank you so much, Michael, for your time and for talking with us today. And thank you, everyone, for attending this talk. We at Magnimind, we try to hold these talks to inspire people to keep furthering their learning. So if you came here, you did that today. If you haven't already, please make sure to subscribe to our YouTube channel, Magnimind Academy, and please tell us what you think about today's meetup or about our online Zoom format in the comment section. Also, please join us for our next scheduled meetup, which is going to be on November 4th. It's called The Surprising Usefulness of a Single Decision Tree. Thank you, everyone, and have a good night.
Thank you. Thank you for all your great questions, and thank you for having me.
All right. Thank you all. Good night.